Welcome to this new session of the International Deprescribing Journal Club. My name is Camille Gagnon. I will be moderating this session today. I am a pharmacist and the Assistant Director of the Canadian Medication Appropriateness and Deprescribing Network, also known as CADeN, which you may hear throughout this presentation. It's a pleasure to see so many of you already on the line and more people joining. People who all share the same passion and interest for deprescribing. As you see on the slide, this journal club is a collaborative effort between the Australian Deprescribing Network, the US Deprescribing Research Network, the Network of European Researchers in Deprescribing, the European Society of Clinical Pharmacy, and CADeN. We are also delighted to welcome a new partner, the German Deprescribing Network, or GERDEN. You see their logo there. So I know some GERDEN members are supposed to join today, and I'd like to welcome you. Willkommen. Sorry, my German isn't great. We are also grateful to partner today with the Quebec Pain Research Network to co-host this presentation, which focuses on deprescribing in chronic pain, which we know is a clinical area where the needs are so important. So a special welcome to all the QPRN members who are here with us today as well. The Canadian Medication Appropriateness and Deprescribing Network, CADeN, honors the traditional territories upon which our directorship, staff, members, and partners live and work. CADeN holds offices in Tiohtià:ke, Montreal, the unceded territory of the Kanien'kehá:ka Nation. Tiohtià:ke, Montreal, has a long history as a place of gathering and exchange for many First Nations, including the Kanien'kehá:ka of the Haudenosaunee Confederacy, Huron-Wendat, Abenaki, and Anishinaabe. As part of a commitment to truth and reconciliation, CADeN resolves to build strong relationships with Indigenous communities from coast to coast to coast, and to partner with Indigenous communities in research and actions reflecting their priorities and their ways of knowing and being. Furthermore, we aim to engage in projects to decolonize and produce culturally safe resources that support communities in the goal of promoting health and eliminating medication-related harm. Finally, as we discuss medication safety and deprescribing today during this journal club session, it is important to recognize that Indigenous peoples experience inequities in numerous health outcomes, including polypharmacy and medication harm. CADeN receives a financial contribution from Health Canada. It is important to recognize and thank our funders, and to say that the views expressed herein do not necessarily represent the views of Health Canada. As a reminder for regular Journal Club participants, and also as new information if it's your first time here, why are we here? Well, all of the organizations that I mentioned initially share a common goal, which is to promote and research the safe and appropriate use of medications. So to advance this goal on an international level, we needed ways to connect and exchange and discuss ideas, publications, and complex clinical cases like it'll be the case today. Our aim is really to foster connections and collaborations while sharing the latest research on deprescribing. Here's a brief agenda for today. We'll start off with a presentation with Dr. Pinard, which will be followed by a Q&A session. We thoroughly really encourage you to enter your questions in the chat as the speaker presents. Our team will be monitoring them and submitting the selected questions to Dr. Pinard at the end during the Q&A session. You will also have the opportunity to ask your questions verbally. And we encourage you to use the raise hand function to do so on Zoom. And we will be asking you to unmute at that time to ask your question at the end. The goal of this journal club really is to foster meaningful exchanges between speakers and participants. And so we highly encourage you to submit questions as they really enhance the quality of the session. And a kind reminder to end our housekeeping that to ensure good quality of the audio during the speaker's presentation, please make sure to keep your microphones muted. And because not everyone is able to attend live, especially because this is an international initiative and time zones make it quite challenging, we will be recording this session and we will be posting it on our website at the URL you see there. And all of the recordings of our previous sessions are available as well on this webpage. Now, without further ado, it is my pleasure to introduce our speaker, who is a member of the Quebec Pain Research Network. Dr. Marie Pinard is an anesthesiologist and head of the chronic pain department at the Quebec University Hospital Centre. She is a full professor at the Faculty of Medicine at Laval University and a researcher at the Centre interdisciplinaire de recherche en réadaptation et intégration sociale, or CIRRIS, which has the mission to develop and mobilize the knowledge that enables social participation of people living with disabilities. Dr. Pinard holds the leadership chair in chronic pain education, aiming to improve chronic pain management and provide patients with validated resources and self-management tools. She is involved in various chronic pain initiatives at the provincial and Canadian levels. So, Dr. Pinard, it's all yours. I will stop my screen sharing and invite you to start your presentation. Thank you for being with us.
Thank you. I will start sharing, see if it works. Is it all good?
Looks great.
Good. So I'm just gonna move this so I see my slides. So thank you, Mrs. Gagnon. I'm very happy to be here with you. As you hear my wonderful French-Canadian accent, you can hear that English is not my first language, although I think you'll be able to understand me. Sometimes I may be mispronouncing medication name because I never tell them in English. So hope it's okay with you. So I'm going to talk about deprescribing in chronic pain, discussing two complex cases that took place in the last 2 years. Of course, some information were changed, the patient's name and certain details to make sure that we don't identify the patients. And before that, I would like to say that I haven't done this by myself. I have the great pleasure to work with some wonderful pharmacists at our clinic that are part of the team. So thank you, Marie-Josée, Dominique, Émilie, and Sonia. And I know Dominique is with us today. So it's really a teamwork, and I'm going to let you know how we work together and what we can offer to family physician or first-line practitioners regarding help for medication on chronic pain. So the first case, it's Elizabeth. She's 35 years old. She recently moved to our region. She was living in another area of the province before, and she was referred to us by a physiatrist who met her at a rehab center. She has Turner syndrome, and she had medullary ischemia during surgery when she was an infant. So she has some pain and some issues walking related to that event. So I met her first in July 2023. Elizabeth lives in an apartment next to her mother's because she needs some help to do her activities. And she's with her, and they're both really nice and very happy to be there. So Elizabeth has low back pain, which is kind of nociceptive pain, and painful numbness in her feet related to the medullary ischemia she sustained. So it's like kind of neuropathic pain. And she also has diffuse pain and some muscle spasms, so kind of nociplastic pain, and maybe some secondary effects of opioids. So most of our complicated patients have the three types of pain, so which is a challenge regarding medication. And she also complains of brain fog, fatigue. She says her sleep is okay, but she's often tired, even after a good night of sleep. She has no clear diagnosis regarding mental health. You'll see with her medication that someone somewhere had a diagnosis for her. And she just says, well, I have anxiety and nothing more than that. She's been on opioids for the last 6 years, which were started by her family physician many years ago. And actually, she has no family physician. It's a reality in the province of Quebec. A lot of patients don't have a family physician to refer to. So it's very difficult because when we're there as specialists, there are some other areas we are not able to take care of. So at our first visit, her medication was long-acting morphine, 30 milligrams in the morning and 40 at night. And she was also taking short-acting morphine, about half or a few pills per day of 5 milligram. She was also on venlafaxine and gabapentin, and using a topical cream that was NSAIDs, ketamine, and lidocaine. And this was only for pain, because she was also taking all of this. I won't read that to you. You can read it for yourself. But she was having a lot of medication for 35 years old, she was generally in good health beside her Turner syndrome and her pain and spasticity related to her medullary ischemia. But it was a lot of medication. So no surprise she had a brain fog. So after the first appointment, which was with myself as a doctor and a pharmacist of the clinic, we decided to start to taper gabapentin first. She wasn't sure it was helping her, and she's been on that medication for many, many years. So she was taking 300 milligrams 4 times a day. So we decided to taper very slowly, 100 milligram every 2 weeks. So it's a long, long. It takes a long time to taper, but we feel it's the way to do it, so we don't have an increase of pain or anxiety or sleep problems. So it went well. Whoops. It went pretty well after a few months. In September, we met her in July. In September, she was at 100 in the morning and 200 3 times a day. Globally, she felt that her pain and anxiety were increased, so we decided to keep it like this for a month. We have to remind that gabapentin and pregabalin as well also work for anxiety and sleep. So sometimes when you taper, the pain is okay, but there's more anxiety. In this case, there was a little bit more of pain and anxiety. So we kept that for the same dose, and we decided in October, a month after that, to rotate opioids in order to try to taper more and even stop the opioids. So she was taking 90 milligrams a day of morphine, and we decided to switch to hydromorphone with 5:1 equivalent and reduction about the quarter of the dose. So this is what we gave her. We gave her hydromorphone long-acting 6 milligram twice a day, and we gave her access to 1 milligram short-acting 2 times a day. And we phoned her every 2 days, gave her, of course, the phone number of the clinic, and it went pretty well. She had minor withdrawal symptoms like anxiety that she was already having, and a bit of nausea, but not much more than that. And our pharmacist advised her to use her topical instead of short-acting hydromorphone, and it was very, very effective. So she was using she stopped using it, and this was a very good advice. So try the topical first, and if it doesn't work, then take a pill of hydromorphone. But it was pretty effective in reducing her pain, in reducing use of medication and anxiety as well. So this was in October 2023. In November, a month after that, she was better overall. Sometimes we have to give the body time to adjust to the medication. Pain was pretty much the same as before, but she was really unable to taper the short-acting opioids. She was taking her 2 milligrams every day. Sometimes it was pain, sometimes we felt it was like anxiety, but she had a very strong desire to stop opioids. She didn't want to use that anymore. So as it was November, we decided to just do no change and plan for after the holiday season. So we gave her a few more months. I'm going to the month of April. She was able to reduce her short-acting morphine by a quarter of a pill. And she was pretty happy to say that, but it was still very little change. Her symptoms were stable. So we decided first to continue taper gabapentin, and it was completely stopped without any more pain. So we plan in July to meet her in person just to discuss that, because over the phone it's sometimes pretty difficult. So she came back to the clinic with her mother. We had a discussion, and we felt she was a lot more awake. She was more smiling. We felt she was very different from the beginning a year ago when we saw her. So we discussed and decided on to do a rotation to Suboxone by microinduction. So everything was settled, everything was good, but then she got COVID. So we just took a break for a month and started in August a microinduction in 7 days. Gave her phone calls every 2 days, just as before. Usually we start the medication on a Saturday or a Sunday, so we can call her on Monday. So that's usually how we do things. So she had a bit of sweating and fatigue on the first 4 days, and she was able to stop completely hydromorphone on the 7th day. And this is how we did it. So you're probably familiar with Suboxone pills, which is buprenorphine and naloxone. So we started with 0.5 milligram of buprenorphine twice a day, of course, along with the naloxone, and 1 milligram twice a day for 2 days, and then 2 milligram twice a day, and we stopped hydromorphone. And as she felt a little bit sleepy in the morning, she was taking her first dose around 8 in the morning, and at 10, 11, she was feeling very, very sleepy. So we divided the morning dose in 2 doses. So she took in the morning, in the afternoon, and at nighttime. So this was in August, and in October, she was feeling a lot better. She had less pain. She probably had opioid hyperalgesia. And we realized with her that she forgot the dose in the afternoon most of the time. So we just stopped that dose, and she was on 1 milligram in the morning and 2 milligram at night. And now we're looking at help to revise the rest of the medication, the psychiatric medication. As an anesthesiologist, I don't feel very comfy doing that. So we're trying I think we found a family doctor finally that we will be able to help with that. But this is sadly not our area of work. So, but she was very, very happy with what we did. And we have a new Elizabeth in 2025, and it was very nice when we saw her the last time. She had a wonderful Christmas holiday. She was able to attend family reunions, which she wasn't able to do because she was too sleepy. She had fatigue. And now she was very, very happy. And a lot of her family members said, "Well, we've never seen you like that in years." And she attends now crafting lessons and goes to the swimming pool, which she wasn't active at all. So this is a very impressive result, and we're very happy with that, and so is her mother. So the key messages in this case, I think tapering must be very personalized. We should take time and take into account what is happening in the patient's life when there's something special happening. It's not time to taper medication. It's time to be stable and just wait. As I said before, gabapentin also affects sleep and anxiety. So sometimes it can be more difficult tapering because of that. Here, Suboxone was a very good solution. She was probably having hyperalgesia, and opioids and gabapentin probably contributed to her fatigue. And as resources is a problem everywhere, I'm just going to let you know how long it took to do that. So we had about 2 hours of in-person visit with the doctor and pharmacist, and 29 phone calls by the pharmacist, which I evaluate at around 12 hours total. So I think less than 20 hours of professional time, it's a very good investment for someone who is 35 and now doesn't have any more opioids. So I think it's a very good example how tapering can be offered, but it took a year and a half. So it takes time. It takes time and resources. So I think we're going to keep the question and discussion for the end. So I will jump to the second case. This is Nancy. She's 45 years old. She has a genetic neurologic disorder with progressive muscle weakness. She's still walking a bit, but uses the electric wheelchair most of the time. She has type 2 diabetes. She has severe obesity and severe sleep apnea. She has a BPAP at home. She was referred to the pain clinic by a doctor in a walk-in clinic because she doesn't have a family physician. Her family physician retired few years ago, and now she doesn't have any follow-up. And she was still having on an open prescription epidural infiltration for low back pain 3 times a year, and had shoulder infiltration 3 to 4 times a year. And indications weren't that clear why she had that, but she says, well, it helps a lot. So the first appointment she came in, which I remember that very well, it was in the fall 2022. She was literally falling asleep in my face. So her eyes were closing, her head was falling, and she was very, very sleepy. And I said, well, is it like that every day? And she said, yes, I'm like that every day. So I was pretty worried. She had a very, very old wheelchair, which was clearly not adapted to our severe obesity. She had no idea of how her diabetes was controlled, and she had no verification of her BPAP in years. So first thing I did is I referred her to the physiatrist, the rehab team, diabetes team, and pneumology team for her BPAP. But the thing is, it's not in the same hospital, so it's very difficult to work as a team around the patient in those cases. So, but I was very happy that she met some of my colleagues. Regarding medication, she was taking, I'm sorry, it's written statics. It should be morphine, 10 milligrams, 7 pills at night before sleep. She was taking duloxetine, 90 milligrams, pregabalin, 75 in the morning and 300 at night. Tylenol, which is acetaminophen, I'm sorry again, amitriptyline, topiramate, and cyclobenzaprine. So she was having a lot of medication for pain and even more for the rest. So I'll let you read what she has. She was having a third anti-epileptic drug here. We weren't sure why. So that's what she had when she came in, and represcribed by walk-in doctors in walk-in clinic without further investigation. So in fall 2022, she had I met her the first time. As I said, she was falling asleep in my face. And she was saying, well, long-acting opioids don't work for me. I've tried that before and doesn't work. So I need my 70 milligrams of morphine at night to control my pain so I can fall asleep. And she was waking up every night around 3 or 4 in the morning with pain, anxiety, and sweats for years. But she didn't want long-acting opioids at first. So I referred her to the pharmacist. They did a phone evaluation, a very long discussion with education on polypharmacy, education on chronic pain. And finally, she agreed to try a 24-hour morphine formulation. So thank you to the pharmacist who did all the education and the discussion with the patient. So, and we decided also, not at all at the same time, to taper cyclobenzaprine, to taper quetiapine, and to taper amitriptyline. And we also decided to hold on infiltrations just to see how things were going, as she was also she also went to the rehab center and would be seen by a physiatrist. So we didn't want to mix everything up. So we started at the very same dose she had. She was taking 70 milligrams of short-acting morphine. So we started on 24-hour morphine at supper time so it can cover better the night period. And we added, because she was very anxious not to have any short-acting morphine, we added 10 milligrams just before going to sleep. So after a few weeks of that, she said, well, sleep induction is more difficult, but when she was asleep, her sleep was really better. And she stopped waking up at 3 in the morning with pain and sweat and anxiety. So this was very nice improvement for her. So rapidly, we started tapering cyclobenzaprine. So she was at 10 milligrams. We went to 5 milligrams for 10 days, then we stopped. And after 2 weeks, she said, well, I'm really less sleepy during daytime. And she was very happy with this improvement. and her pain went down from 8 on 10 to 4.5 over 10. So it was very impressive how long-acting opioids and stopping just one medication so she'd be less sleepy and more active made a very big difference. And of course, she was eager to stop more pills. She was very happy with the result. So we started reducing quetiapine. We weren't sure why she was taking that much medication. So we started reducing, and then we decided to switch to amitriptyline for the next reduction. So we went to 75 to 50 milligrams. And she was more awake. Her sleep was pretty good, but she was still sweating a lot. This was a main concern for her. And we decided to stop pilocarpine. We didn't know why it was prescribed, probably for dry mouth, because of all the medications. She was anticholinergic medication she was using, but now she was having less, so it was probably not required. So it worked. She was sweating less. But sleep was more difficult with the reduction in quetiapine and amitriptyline. So we started a very small dose of metotrimiprazine that we sometimes use for pain and sleep. So it was pretty effective, but everything was stopped because she needed to have knee surgery. So we kept the medication in the winter 2023 the same, awaiting the surgery, which took place in the beginning of, I said 2023, but it's 2024. Sorry about that. So in spring 2024, she had her surgery. Everything went okay. And we did a lot of medication so that she would increase her morphine after her surgery. Of course, she had more opioids around surgery, which is very normal, but it was okay and it worked. Then when she was better in spring 2024, we finished the tapering of quetiapine and had to increase metotrimiprazine to 10 milligrams to increase her sleep quality. But then with that, sleep was okay, pain was okay, was still like a 4 on 10, which was about half of what she's having before. She finally had an appointment in pneumology. Remember, she was having a severe sleep apnea and was on a BPAP, and her test was highly positive and concerning for sleep apnea. So we tried to decrease long-acting morphine by 10 milligrams, and then we were unable to reach her for a few weeks. It was summer 2024. Sorry for the mistake. And she had a phone problem, and we were pretty worried because for weeks we didn't have any news. But we knew she was receiving her medication from her pharmacy. So finally, we got her new phone number. She got a new phone, and we were able to catch up the follow-up. And at that time, pain was a lot higher. The reduction from 70 to 60 milligrams, it was very difficult for her. And she used more short-acting morphine, but she ran out of tablets at the end of the month. So she was like not very happy with that. And at that time, she had a lot of pain in her ankle. And we discovered that she'd need to have another surgery after the knee, then it was the ankle, and the surgery was required. So we agreed on re-increasing the 24-hour morphine at 7 milligrams at her previous dosage, and agreed on 2 short-acting morphine, 10 milligram short-acting morphine pills a day, so that she would be more comfortable awaiting the surgery. So in fall 2024, surgery was okay, but she was unable to work for 3 months because the healing of the skin was very, very difficult. So this was really difficult for her, and we met her in person just to make sure everything was going okay, and to discuss with her where do we want to go. So we did a lot of education on opioid risk again, including what it meant with sleep apnea. And she admitted to stockpiling tablets and sometimes taking 3 at a time, which was pretty dangerous in the context of sleep apnea. So we instead of servicing the opioids for 4 weeks at a time, we did that for 2 weeks. We would have liked to do less, like 1 week service, but it was very complicated for her as she was living pretty far of her pharmacy, and delivery was sometimes difficult. And baclofen 10 milligram was added by the physiatrist because she was having sometimes muscle spasm, and he believed it was related to her medullary problem and not to opioids. In fall 2024, we just looked back at her pills, and she was on 3 anticonvulsants drugs. So she was having topiramate for pain, pregabalin for pain, and levetiracetam for we don't know what really. And we discussed that with her, and we decided to taper topiramate. And this was very difficult for her. She had a lot of anxiety regarding tapering more medication, even if she was better with the changes we made before. So in winter 2024, now the year is okay, she asked for another in-meeting person. So we met her, myself and the pharmacist. And she told us that she was very, very anxious to taper more medication. Her pain was still 4 and 10. Just a reminder, it was like 8 or 9 on 10 before that. Her sleep was okay. She started a rehab program, and she said, well, I just want to keep things like that. I don't want to go any further in tapering. And I have too much to do, too many doctors to see, too many things to do with my rehab program. So we decided to stop the changes. And we agreed that she had a lot of other health problems to look after. See, her obesity, which was already severe, increased a lot due to the fact that she wasn't walking for 3 months after her ankle surgery. So it was a very big problem. She had severe fatty liver, or diabetes. She has resources to help, but was very, very difficult to control. She was smoking and was still smoking despite many advices and education on that. And so we were pretty happy with the changes we made. We changed her morphine for 70 milligrams short acting to 24-hour formulation. We tapered 3 medication and reduced amitriptyline. And she didn't even talk about infiltrations anymore. So no epidural infiltration, no shoulder infiltration. And she was under the good care of my colleague physiatrist for those aspects, but she didn't have any more infiltration. And she wasn't sleeping in our face either. So what we did is we planned an appointment per year to do the prescription, waiting to have family doctors and see if she wants to modify more of the medications. So we met her recently to prescribe. That was in winter 24. We agreed on that, but we just met her back in winter 2025 to make the prescription for 1 week, but for 1 year, and she was still doing pretty good. She had a very precarious socioeconomic status, so her apartment was poorly adapted, and this was she was very worried, of course, with that, and we're trying to help her, but we don't have many resources at the pain clinic for that. So the physiatric team, diabetes team, they're working with her, and she was still very, very happy and proud about the changes she made in her medication. So talking about resources, it took about 6 in-person visits. I think 4 of them were with the pharmacist and the doctor. It took maybe 4 hours for 6 visits and 23 phone calls, so maybe 10 hours. So again, it's a lot of hours, a lot of time, but for the benefit, I think it's really worth it. And what have we learned from this case? Well, she was probably having withdrawal symptoms every night, and this was very bad for her sleep and everything. So I think she's doing really better with long-acting opioids. And it's difficult to address all those problems and all the problems of one person in a holistic way when the teams aren't in the same hospital. So it's pretty difficult, and we're counting on good relations with colleagues to refer people and hear about it. So it's pretty difficult. She has much better pain control and sleep control with the same dose of opioids. And we have to respect the patient's preference. It would have been nice to taper more medication to lower opioids, but I think she was happy with that, and still it was small steps, and we did some, and maybe in the next years we'll be able to taper more medication. And of course, a family physician would have been very helpful in this situation, but she doesn't have one. So for the moment, she has to rely on different specialist teams. So those were two cases I had to present. I'm going to take a few more minutes just to let you know the wonderful thing we're doing. I think it's wonderful with the pharmacist. So we offer family physician to refer patient to the chronic pain clinic for advices on pharmacological aspect of chronic pain. So I'm going to describe you what we do and how we do it. The challenge is waiting list. We have a very, very long waiting list at the pain clinic, and it's the case probably across the country. And it's very difficult to have a timely appointment, the appropriate treatment at the right time for patients. Often they wait too long, and with all the consequences we know. So the solution was try to support first-line practitioners, either nurse practitioners or family physician, to help them with the medication for the patient with chronic pain when people don't necessarily need interdisciplinary treatment, infiltration, or rehab, and the scope is really the medication. This is where we can do a difference. So we do evaluative consultation and discussion with the patient. This is how it works. When we receive the consultation and we know it's for medication, our nurse first explain the offer to the primary care physician who referred the patient. It's by a letter, but sometimes they have to do phone calls. And then when the doctor says, well, I agree with this offer, then the nurse gives the patient a call just to let them know what we're going to do, and that he won't be seen in person, and that he won't have a long follow-up at the clinic. Then the pharmacist take about 2.5 hours, sometimes it's more, sometimes it's less, to review the medication history in the last, let's say, 10 years of the patient, and have a phone discussion with the patient on what is the actual medication, what are the effects, the secondary effects, what medication what kind of medication was tried before, and why was it stopped? Was there allergies or whatever? And then they make suggestions for the family physician and write a report that is very clear. If they say, let's say, taper pregabalin, they just they write the calendar so that the family physician knows exactly how to do it and what to look after if there's withdrawal syndromes and everything, symptoms and everything. And then when the report is written by the pharmacist, an anesthesiologist takes about, let's say, half an hour to 45 minutes of discussion with the patient. They discuss the conclusions of the report of the pharmacist. And the anesthesiologist has to also write a report. And all of that is sent to the family physician, who will be the one making the medication changes for the patient. So we don't prescribe, we don't take charge of the patient, but we are there over the phone to support the family physician if they need. And it's really effective. We reduced our waiting time. We do about 50 a year. So it's 50 patients who don't have to wait, 50 patients who don't have to be seen in the clinic, and they still benefit from the clinic's expertise. And we think it improves the management of chronic pain by the family doctors because they get advices they can apply for other patients. And we had the chance via the QPRN to study our first 50 cases, and all except one family physician made changes that were suggested, and 98% of the family physicians were happy with that. So we get a lot of referral for that, and I think it's a very good way to use the resources to support the family physician. Finally, I just take a few minutes to talk about Gérer ma douleur, which is manage my pain. This is the chaire de leadership en enseignement sur la douleur chronique, the leadership chair in chronic pain management. It's a program at Laval University that aims at improving the readiness of Laval University graduates to work in their fields. And in our case, we're looking to better serve the population and offer an opportunity for continuous medical education. So gérersmadouleur.ca, which is also available in English, you just have to switch the language. It's a website, it's a portal where you're a patient, you can access quality resources. We looked at different resources that were available for patients and siblings regarding chronic pain, and we looked at mainly three quality criteria. Do we know who wrote, who did that resources? And most of the time, we don't know who wrote that, so it's not very practical. And we also need to know when was it created. Is there a date, a month, a year that is available to know when this resource was created? And then is there scientific references? So those were our three criteria. And we looked about to more than 4,000 resources. And we asked ourselves, is there an author, a date, and references? And when there were two or more, we give that to chronic pain experts in different professions, physiotherapists, pharmacists, occupational therapists, psychologists, doctors, to make sure that it was relevant, it was clear, and it was consistent with the message we're trying to give out to our patient. And to 4,200 resources, we have less than 270 on the website, actually. So on the website, this is what you see. You see many, many, many resources. You have the title and the language. You have some in English, some in French. And you have the type. So this is like a written resource. Sometimes it's video, sometimes it's podcasts. The language here, and just a link to consult the resource. So most refer to external websites. And this is available, and it's alive. We add many resources from day to day. So if you're ever interested in submitting some resources you're using, you're more than welcome to do it. And there's also on the website Agir pour moi. I'm sorry, it's in French because Agir pour moi for the moment it's just in French. Agir pour moi is a self-management program that is over 8 weeks, so an hour and a half a week for 8 weeks, where we literally take patients by the hand and tell them about what is chronic pain and what are the different self-management tools and technique to improve chronic pain. And this was co-constructed with 7 people living with chronic pain, and 5 of them are giving testimony during the whole program. And good news, we're going to have that translated to English in fall 2025. So it's going to be available in both language. And we tell patients it's like a tryout menu, a degustation menu. You just try many things, and then you find for yourself what's better, what you prefer. So it's pretty effective. We did a few studies on the program, and of course, it's better when you have a health professional that is helping, but this is meant to be done by people themselves at home. And we also have a section for healthcare professionals. This section is only in French, but there are a few resources in English. So we have resources like conferences, websites, videos, micro programs, and so for healthcare professionals that want to improve their knowledge in chronic pain. And we also have 50 short learning capsules that take about 15 minutes to do on different subjects. Those are only in French and will stay in French, but if you want to take French lessons and use that, or if you speak French already, this is readily available. You can connect to the website. You have to create a profile. as a health professional, but it's free. And we don't sell the list or everything to anybody. It's Laval University, so don't be scared about anything. We're doing things correctly regarding internet regulations. So this is the website. This is my email address, and right on time at 12:45 here, I'm ready to take questions.
Wow, yeah, right on time. Thank you so much, Dr. Pinard. I think you did an excellent job of both guiding us through these very complex cases and then ending with those presentation of resources. I know this is something that participants have an important appetite for, and even if they don't speak French, you know, in the case where the resources were available in French, we all are curious to find out what exists out there and what could be, you know, how connections can help us and inspire us to develop, you know, similar resources in other languages. I certainly appreciated the way that you showed how your team tailors your approach when you have a patient, say the second patient you admit, right? You would have loved to
Yeah.
do more, but she wasn't necessarily ready for that. And that is
Yeah.
an important learning, I believe, for in our deprescribing journey for these patients.
Yeah.
I also appreciated that you showed the value of the interprofessionality in your approach with those patients. I can't even imagine when they don't have family physicians how complex it can be. And you did a great job of showing how you move forward and are able to help them. And finally, the idea to show the sheer volume of resources that you put forward for a patient for important results. And firstly, the first patient having this patient off of opioids at such a young age
Yeah.
is for the 20-ish or less hours invested. Sounds like a very good investment of time and human and health resources. We
Yeah.
have very
And
excellent questions. Yeah.
what I didn't mention is, of course, we involve the community pharmacists in that. Our pharmacists also give phone calls to the community pharmacists, and they're usually very helpful and very happy to give the patients less medication as well.
I appreciate you mentioning that because I'm sure that was a question that some of our participants might have had. I have questions that I'm going to ask in the chat. If ever you're interested in asking your question verbally, please do raise your hand with the Zoom function, and we will try to make our way and have you ask your question. So there's an excellent first question to start from, and I'm sorry if I don't pronounce this well, Mette Lundberg. Is there a general consideration of which medication group or category you will taper first, Dr. Pinard?
No, not really. It depends on the patient's preference. And sometimes they say, well, I take this and it doesn't do anything. So sometimes this is the one we were going to start to reduce first. And as I always say, the first, whatever the medication is, the most important reduction is the first one, because it's going to give them confidence that they're able to do it. So usually when we reduce opioids, which was not maybe very well seen in those two cases, but sometimes we do very insignificant reduction the first time, just to let the patient know it's possible and let them know that we're going to be there. And whatever the medication we taper, I think one of the most important thing is to let the patient know we're going to be there. We want him or her to be better, not worse. Even sometimes you have to pay the price of being less, to be more, well, in pain or anxiety or whatever for a few days. But this is not what we want. And when we start with very, very small steps of the first time, we give the patient confidence that we're going to be there, and we're going to call them. And sometimes what happens is people want to go faster. Now they feel confident and they want to go faster, and sometimes faster than we would like to do. But it's very nice when this happens, that, well, they know they can do it. So it depends on the cases. Sometimes people are very willing to taper opioids. They want to get rid of it. And sometimes they're just scared to death to taper opioids. And sometimes, well, we say, well, okay, we're going to keep your opioids like they are, and we're going to taper something else. And now they get more confident. And sometimes we start to taper one and we stop and we start with another one. And in the end, we just want to taper any medication that is not useful anymore.
Yes, and to continue on with Mete's question, there was a question regarding gabapentinoids and opioids. When you see those co-prescribed, do you have a preferred approach in terms of speaking with the patient in terms of deprescribing? Is there one that you would go deprescribe first based on your experience, or it will really vary?
It depends what the patient preference is. It depends also if they have problems sleeping or if they have anxiety, because gabapentinoid, they work on pretty well on sleep and anxiety. So sometimes when this is already a problem, this is not a one I'm going to stop or taper. I'm going to start with opioids. And from my experience, we know that sometimes with opioid tapering, even if it's not to zero, people tend to sleep better. Not at first, but after a few weeks or months, they tend to sleep better. And then it may be possible to taper something else. But for some patients, and I think this is also a very important message, we're not able to taper to zero, to whatever the medication is. In many cases, sometimes people were on opioids for a very long time. We're just unable to go to zero. But if we go to, let's say, 500 milligram of morphine equivalent to 50, well, this is success for me. And we have to tell the patient before that success is not measured by no more opioids. Sometimes it's a lot less opioids. And it's the very same for pregabalin, let's say, for example. Sometimes people have to keep a small dose at night because it helps control sleep and anxiety. And sometimes 2, 3, 4 years after, they're going to be able to stop. And it's a very important message that success is not measured by no more medication.
Important takeaway. I'll move over to Anne Spinwin's question. She's asking, are there any specific tools that you use to take patient preferences into account? It's an excellent, follow-up from this first question, to relate to goals, values, or preferences.
Yeah. No, it's I'd say it's probably clinical experience. You see my gray hair. Yeah, I've been doing that for 23 years. And I think also what is really helpful is the team approach. I talked a lot about pharmacists, but we also have nurses, physiotherapists, occupational therapists, psychologists. So sometimes for some patients, they meet with other members of the team, and maybe they're more into expressing this to the psychologist. So then we talk together and we make a plan. And I think the most important thing is keeping the patient's motivation to do the tapering and letting them know that we're going to be there, and just start somewhere. The first step is most of the time the most difficult. And no, I don't have a very special. It's much with the discussing with the patient and what they think is effective or not. And sometimes we have surprises, but we are there to adjust things. And it takes very regular contact with the patient to succeed, I think.
I see that we have a hand up, so I'll invite Rajneesh Kaur to speak and share their question.
Hi, hello, can you hear me?
Yes.
Yeah.
Hello, Dr. Pinard. I just wanted to ask, when you, amongst your patients, did you come across any patients who, when they were excited about coming off the medication, that they wanted to come off a medication perhaps that wasn't medically advised? And if the healthcare professional advised not to do it, did you come across anyone who did secretly do it and actually come off any such medication, and were there any consequences to that?
I'm not sure I heard the question very well. You said, well, if we advise sometimes the patient not to taper some medication?
Yes. But then did they secretly, did you come across any patients at all who, like you said, they were excited about coming off a particular medication, but perhaps, you know, you felt it was quite dangerous to do that, and
Yeah.
what happened in that situation?
Yeah, usually, and you'll let me know if it answers your question. When we first meet with the patient and we look at the medication, we tend to tell them that some of the medication they should not stop by themselves, even if they think it's not useful or it's.
Okay.
So I think that's pretty much with education. And sometimes for opioid tapering, it doesn't happen often. It haven't happened in many years, but a few years ago it happened that people were willing to stop right away. So yes, it gives them withdrawal, severe withdrawal, but it takes 3 days and they're off opioids. So if it's accompanied medically, I think it's okay. But we tell them not to taper like pregabalin, to stop that right away, because there's a risk of delirium. And so we teach them, we let them know what are the dangers of stopping medication by themselves. And we invite them to give us a call or just tell us at the next appointment if they are willing to stop something very fast. Or I think it's a lot about the conversation that takes place. I don't know if it answers your questions, but
No, it's fine. But I was just curious if you know, if you've come across anyone like that.
Yeah.
But that's fine. That's perfect. Thank you.
I see our times are almost up. Maybe a quick fire question to end the questions period from Mette Lundberg again. A question about tricyclic antidepressants.
Yeah.
They are wondering, do you involve psychiatry when you are looking at these types of medications, or quetiapine when you are deprescribing? What considerations do you have?
It depends on if we know the reason it was started. And tricyclic antidepressant usually in our clinics are used only for chronic pain. So we don't really need the psychiatrist to deprescribe. And it depends sometimes, and sometimes we have to call the psychiatrist if there's one, just to know what was it prescribed for, and can we reduce the dose or can we change something. And it's all about collaboration and trying to work as a team. And it's really amazing that our pharmacists, they do that. They call some of my colleagues just to discuss, and usually it goes very, very well, and they're willing to collaborate. And it's very difficult when you have such medication and you don't know the reason why it was started, and there's no psychiatrist or family physician. So this was the case with Elizabeth. We didn't know why she was taking so much medication, and she didn't know either, and her mother either. So we had to finally, I think we found someone to help us deprescribe. But yes, sometimes we have to involve other specialists and let them know, and it's all about, again, collaboration and discussion.
Thank you. Thank you to everyone as well for your excellent questions. I got a good discussion going. Really appreciate it. To end the session, it's almost we're almost out of time. I want to thank you, Dr. Pinard, for generously sharing these cases and your learnings. I'm sure everyone can leave the session with pearls that they can hopefully apply for their research, their clinical practice to help patients, and the tools that you shared. We will be able, following the session, people will be able to access the recording, but we'll also put the links to those resources. We do want to take this opportunity to promote the next session of the International Deprescribing Journal Club, which will be on Friday, May 23rd, and it will be hosted by our friends, the German Deprescribing Network, their first session. We'll have Dr. Karen Voigt present Delta Pia controlled discontinuation of levothyroxine in subclinical hypothyroidism, a participatory intervention approach. So you can, we're going to put the link in the chat if you want to sign up right away, hold that time in your calendar, or there's a QR code here to scan. We're also going to launch just now a survey. We want to know what you liked about the session. We want to keep people engaged. So what you preferred, what you would like to see in the future. We thank you for taking the time to fill this quick survey. And if you want to stay involved, informed of our future journal clubs or any Canadian Medication Appropriateness and Deprescribing activity, resource, event, sign up for a newsletter. It's really the best way. And as well, our social media channels are a great way to stay informed. We do want to thank everyone that was involved either in the planning of this sessions or previous one. A special thank you to Hélène Baudry, Yulia Tufa, who are from the Quebec Pain Research Network and graciously helped us with Dr. Pinard, of course, organize this session. So thank you to both of them and to you again, Dr. Pinard. We're happy to end the session now, and thank you for your time, everyone, and for joining us today.
Thank you.
Bye-bye.